Hi, I'm Jerry Hesch from the Hesch Institute in Aurora, Colorado, and I am a physical therapist, and I have developed a unique approach to evaluating and treating the pelvis and the sacroiliac joint, and I started that in 1981. My website is heschinstitute.com, and that's spelled H-E-S like Sam, C-H. And then my video channel on YouTube is Jerry Hesch, again, H-E-S like Sam, C-H. Now what I want to present is comparing the osteopathic muscle energy technique, also known as MET, with the Hesch method of sacroiliac joint dysfunction evaluation and treatment. Number one, the osteopathic method, muscle energy method of evaluating so-called sacroiliac joint motion has been disproven with research that came out in the 90s forward. And what they found is that these gross movement tests where you palpate the PSISs and the sacrum and you have the person bend forward and then you have them stand and lift one leg up and then lift the other one. Those were found to have very minimal motion happening in the SI, less than 2 degrees of glide and less than 2 degrees of rotation. And so the landmark asymmetry that we're seeing when people stand and they lift one leg up and we evaluate movement of the PSIS, that's a movement of the entire pelvis. It's not an accurate evaluation of motion inside the sacroiliac joint. And multiple studies have disproven those techniques. The Hesch approach uses passive motion testing to the joint. If I want to test how the pelvis rotates posteriorly on the left side, I have the patient lay on their back and I push on the ilium until all motion is taken up using approximately 15 pounds of force. That's called taking up the slack. And that's a way of taking away extraneous movement and isolating forces in that joint. And so once we take up the slack, then we add a forward thrust, but what I add to that is I allow myself to perceive the recoil. Other clinicians do some forward thrusting on the pelvis. There's a book chapter on that written by Richard Nyberg in the 80s. And he teaches with Stanley Paris, and he teaches the lumbopelvic workshop. And he uses a forward thrust. I find it more valuable to do a forward thrust and feel the recoil or the lack thereof. So when a structure is stuck and does not move, then it's really easy to perceive that because you won't be able to take up the slack, or the slack may be taken up very quickly and then you cannot spring it. A hypermobile structure, it'll take a while to take up the slack, and then when you spring it forward, there's a very weak or a very limited recoil. So that's a distinctly different way of evaluating motion through the structure. Another thing that differentiates the Hesch method of evaluating and treating the lumbopelvic region with the osteopathic muscle energy technique, I'm going to read this list. The word on the street from a very large number of physical therapists who have taken my SIJ workshops is that muscle energy techniques are only helpful short term. They do not induce lasting change. I used to use muscle energy technique and I used to teach workshops on it, but abandoned it in favor of using very gentle, slow releases, which sometimes take 2 minutes, and I use an applied fulcrum on the pelvis. Sometimes I do a release for 5 minutes, and other times for a specific dysfunction of the sacrum, I do a 10-minute release, but that's a one-time treatment, and the correction remains long-term. Another reason is that the MET model is, the osteopathic biomechanic model of so-called sacroiliac mechanics. And those were described in 1958 by Fred Mitchell Sr. The Hesch method negates 3 of those patterns that simply don't exist when you use additional palpation and when you use passive motion testing. You find out that there's no such thing as a posterior rotation in the pubic joint, and there's no such thing as what they call a unilateral sacral flexion, and there's no such thing as a unilateral sacral extension. And I know that a lot of people are heavily invested in that, but again, they're using limited number of palpatory landmarks and gross movement testing, which really does not isolate movement in the SI joint. The Hesch method was developed from 1981 forward, and I have discovered 15 patterns of movement dysfunction that are not described in the osteopathic model. So I therefore claim that the MET model is an incomplete biomechanical model of movement dysfunction in the sacroiliac joint, in the symphysis pubis, and of the whole pelvis moving as a unitary system. Some muscle energy treatment techniques are performed at the wrong angle or at a suboptimal angle. For example, you'll see on YouTube, you'll see techniques where people are supposedly trying to correct an anterior ilium, and they hug their knee and they push forward into their hands for 10 seconds, and then they relax, and then they stretch their knee upward. That is an effective stretch for the opposite iliopsoas muscle. It might even relax the same-sided iliopsoas, because if you're resisting upward movement and then releasing, that will fatigue that muscle also. So it can be done two ways. But if you want to capture the ideal angle to move the whole pelvis, or if you want to capture the angle that parallels the SI joint, you do a similar technique, but you take the knee outside of the shoulder. And that is much more effective, and there is much more available range. And then you're doing a much better job of stretching the medial hamstring and of the adductor muscles, which can influence pelvic position. In the muscle energy model, they teach pubic popping, where you resist horizontal abduction at the knees. Knees are bent and you're resisting that 3 times 10 seconds, and then you resist pulling in together using the adductor muscle groups 3 times 10 seconds. And you will often feel a pop, and you may feel better. Many people do. And what I think the popping is I believe that is the adductor tendon creating a vacuum phenomenon inside the adductor sheath. I don't think that joint creates a noise. There's not a vacuum phenomenon inside a fibrocartilaginous joint. So it's not the pubic joint popping with an adjustment. The pubic joint in most people is a very, very strong joint. The fibrocartilage is 1.25 inches tall. It's 1 centimeter deep. And although it's only a couple of centimeters wide, those fibers spread out from the midline laterally to a considerable degree. They have very thick ligaments posteriorly. Inferiorly is particularly thick. There's a thinner anterior ligament and a thinner superior ligament, but that's a very, very tough joint. I describe it as a motor mount on your car's engine. And a motor mount moves very, very slightly. It's dense rubber. It's a block of rubber. And it's designed to attenuate shock or vibration of the engine. I take 5 minutes to make a correction at the pubic joint. And again, the asymmetry has to be coupled with blocked mobility with the passive spring test. And you can do spring testing directly on the pubic joints, but you can also spring indirectly springing on the flat part of the ischium. A lot of the osteopathic manipulations for the pelvis and sacroiliac and lumbar spine, including MET or manipulation, do not teach the patient self-treatment. For every type of movement dysfunction of the hip, the pubic joint, the sacroiliac joint, the lumbar spine, and the entire pelvis, I have a self-treatment for every single technique that a therapist can do to that patient there's a self-treatment technique that can be taught to the patient. In my practice, I typically see people 3 times. And on the first visit, I will use hands-on techniques. I don't teach them anything to do that day. I want them to come back and I want to see how their body responded to that treatment. But on that second visit, I teach them what to do to maintain that correction. So it's a model that fosters patient independence, puts them in control, significantly reduces their health dollars spent. And that is the summary of comparison of the Hesch method approach to the sacroiliac joint and pelvic movement dysfunction. Much of these movement dysfunctions are the entire pelvis moving with deformable soft tissue posteriorly. The muscles and tendons that overlie the sacrum are segmentally innervated, and so you can have increased muscle tone on a lower part of the sacrum, and it's easy to ascribe that to being a torsion or rotational pattern of the sacroiliac, when in fact it may very well be a muscular phenomenon. No one has done the research looking at those patient presentations using surgical implantation of titanium balls and then using stereophotogrammetry, which is the standard of care for evaluating SI motion. The tests that use external markers are not very reliable, but again, the research has not been done, and it could be that a lot of these things that we say are movement inside the SI joint are artifact from the whole pelvis being asymmetrical, and even that will reduce motion based on postural asymmetry when we do spring tests. Anyway, that's all I care to say about that. There's a lot of controversy and a lot of debate going on in social media on the sacroiliac, and a lot of people are walking away and doing hands-off. And the Hesch method is a thorough hands-on evaluation technique, but a treatment technique that makes the patients independent of us within 3 visits. Of course, exercise rehab may take longer than that, but you certainly can reduce inhibition of muscle groups by balancing structure. And I thank you very much.